Good morning, muy buenos días a todos y a todas. Vamos a esperar un minuto para que entren todos los participantes para este webinar. Están entrando, ya tenemos más de 200 personas conectados, pero los damos unos minutos más porque recién se abrió la sala. We're just going to wait one more minute to allow people to enter the room. We only just now opened the room to give people access. Good. Well, I think we're ready to start. Muy buenos días a todos y todas y bienvenido a este webinar de la Organización Panamericana de Salud. Our webinar today will be in English, Spanish, and Portuguese. And for this, we have translation. There's a button at the bottom of your screen titled Interpretation, and please select the language of your choice using that button. And we also welcome interaction. We know we will have hundreds and hundreds of people connected to this webinar, but we do want it to be as interactive as possible. So please send us your comments in the chat. There's a chat icon at the bottom of your screen. So please join us today in this webinar on NCD and risk factor surveillance with a focus on telephone surveys. And to begin our session today, we have a message from the PAHO director, Dr. Jarvis Barbosa, who's a public health leader known to many of you and who'll speak to us about telephone surveys as a valuable tool for NCD and risk factor surveillance.
Distinguished participants, ladies and gentlemen, it gives me great pleasure to welcome you to this webinar titled Telephone Surveys, a resource for non-communicable disease and risk factor surveillance. Surveillance is an essential public health function, yet surveillance of non-communicable diseases in the region of the Americas remains insufficient, with persistent data gaps that need to be urgently addressed. Innovative approaches, such as telephone surveys, offer a valuable opportunity to strengthen non-communicable disease surveillance across the Americas and help to bridge these gaps. Surveillance plays a critical role in monitoring non-communicable diseases in a timely manner, supporting the assessment of health policy implementation and informing decisions to strengthen non-communicable diseases responses. Robust surveillance systems also facilitate early disease detection, identify at-risk populations, help to reduce health inequities, and ensure that health systems can effectively meet the needs of people living with NCDs. Today, I want to highlight how telephone service can strengthen our surveillance capacity for NCDs. PAHO's Rapid Mobile Phone Service, RAMS, was launched in 2020 to collect data on non-communicable diseases and access to care during the COVID-19 pandemic, and on the implementation of the WHO Best Bus policies and interventions for NCDs. To date, RAMPS has been implemented in 80 countries in the Americas. It complements household surveys by producing timely, cost-effective data that do not require physical or biochemical measurements. Ahora continuaré en español. Utilizando RAMPS, Uruguay evaluó las percepciones del público sobre el etiquetado frontal en productos ultraprocesados con octágonos negros. 8 de cada 10 personas adultas reconocieron los símbolos de advertencia por exceso de azúcar, grasa o sódio, y el 63% afirmó que las etiquetas influyeron en su decisión de elegir opciones más saludables. RAMPS também pode ser uma ferramenta útil para ajudar a identificar barreiras no acesso à atenção sanitária, como o acesso limitado a serviços integrados de enfermidades não transmissíveis e a falta de recursos financeiros que impide a muchas personas recibir la atención que necesitan. Outro exemplo destacado é Vigitel, de Brasil, uma iniciativa exitosa que utiliza encuestas telefônicas para monitorear as enfermidades não transmissíveis e seus fatores de risco. Desde há quase 2 décadas, Vigitel produz dados anuais que orientam a formulação de políticas e guiam intervenções de saúde pública, adaptando-se de forma contínua às necessidades de informação do país. A região das Américas oferece um entorno propício para expandir o uso das encuestas móveis. Em 2024, as redes 4G e 5G alcançavam o 93% da população. Sin embargo, aún existem brechas. A cobertura urbana é del 98%, mientras que em las zonas rurales é del 72%. Uma disparidade que sigue sendo um desafio. Apesar de essas limitações, as encuestas telefônicas seguem sendo ferramentas rentáveis, ágeis e escaláveis que complementam as encuestas presenciais e fortalecem a vigilância em saúde. A OPS reafirma seu compromisso de apoiar os países em la integração de las enfermidades não transmissíveis em los sistemas de vigilância de saúde pública. Los animo a participar ativamente nesse espaço, a compartilhar suas experiências e conhecer mais sobre o papel que podem desempenhar as encuestas telefônicas para reduzir a carga das enfermidades não transmissíveis em nossa região. Muitas gracias.
Muchas gracias a ti, Dr. Jarvis Barbosa, director de la Organización Panamericana de Salud, dándonos sus palabras de bienvenida para esta sesión de hoy, el webinar sobre encuestas telefónicas. In today's session, we're going to really have a spotlight on the role that surveillance plays as an essential public health function. And in NCDs, a really important function to help guide not only understanding of what the burden of NCDs and risk factors are, but also what the health system response is. And we really want to showcase the use of telephone surveys as an innovative tool to monitor NCDs, and especially looking at how we can monitor access to care and that health system response. And we're really excited because we're going to talk about not only from PAHO's perspective, what's going on in the region on NCD surveillance and how PAHO is committed to supporting member states to strengthen NCD surveillance, but we have with us some of the leaders in the field of NCDs and NCD surveillance from our partners at Resolve to Save Lives, as well as we're going to share some experiences from the region, from Brazil, from Vigitel and Uruguay on ramps, as you heard from the PAHO director. So let's get started with our exciting program today. And I'd like to invite our first presenter to help set the scene for us. She's Dr. Roberta Caixeta, the PAHO advisor for NCD surveillance, prevention, and control. And she's leading PAHO's regional efforts to build capacity on NCD surveillance. And she's going to talk to us about why are flexible and timely tools needed for measuring NCDs. Roberta, over to you.
Thank you, Silvana. Thank you very much for this kind introduction. It's really a pleasure to be here today and help to set the scene of the importance of using telephone service to complement the work that we do on NCD surveillance. We do need tools that help us to produce data in a timely manner, but also guide us towards the implementation of policies. And when we talk about innovative tools, we are actually trying to present this as an approach, as a way of complement the tools that we already have it. We'll ask next slide, please. So I want to start by providing this overview that we've been developing the region as a conceptual framework since we kind of work responding to the demands. Health systems, when it's fragmented, it does reflect on the surveillance system as well. But this is an effort within the region from us to put in one place all the elements that are relevant for integrating NCDs into the public health surveillance. We are not talking about building from the scratch something new, but just to complement and fill in the gaps that we need a lot. And where are the biggest caveats? Where are the important elements that we need to have if you really want to monitor the complexity of NCDs and the burden of NCDs? So this is just an overview. I don't want to go in depth. We have this being presented in Brazil and the meeting on March for some feedback from countries. But the idea is to emphasize that for NCDs, we really need data from all the levels of care, from health promotion to palliative care. We need the information not only for those separate the prevalence that we normally have been doing, and it's an effort that we need to keep doing in terms of knowing the prevalence of tobacco, alcohol, individually, but also understand better the distribution and the population that are living with one or more NCDs. So we have estimated during the COVID that 24% of the population in the Americas were living with at least one condition. We talk about chronic conditions, and this is our aspects that are differentiate from different, let's say, strategies that we have used for public health. So here we have the dimensions that you need to be aware. So we have social determinants of health, but we also have commercial determinants of health that impact with the unhealthy commodities that cause and expose people for getting sick and developing NCDs. We look into the burden of disease traditionally, but we, as I mentioned, need to look beyond that. And also to be clear that data for NCDs come from outside the health sectors as well. On the right side, we have highlighted some of the key data sources, and today when I talk about population-based survey, what are the strengths? We don't have one data source that responds to all of the needs that we have. Would be a paradise if we get there, but we need to understand where we can what are the strengths and where are the challenges when we are using some data. And today we want to talk about telephone surveys as one strategy to fill some of the gaps in the data that we have. And finally, I just want to emphasize here on the left side on the needs of data, on why you produce surveillance, why we are implementing surveillance, as Dr. Jarbas Barbosa and Silvana Luciani mentioned as well, that surveillance is an essential public health function, and which means that we need to strengthen national institutional capacity to respond accordingly. And we need to take advantage of the movement of a strengthened information system for health and digital transformation to really help us to be able to make surveillance for NCD stronger. But one of the aspects that we need to be aware when we are establishing our surveillance system for NCDs is related of these key elements. We have produced data for risk factors. We have produced data for the death and the burden as well. But we need to be more, we need to address some gaps that we have. So data on the implementation and evaluation of health policies. Use it for prioritization exercise, have information on the unmet needs of this population. Household surveys, mobile phone surveys, school-based surveys are key when we gather, for us to gather data. Facility-based data is essential. It's one area that we need to improve in the region. We've in the past have faced lots of challenges. The change is coming. We are happy to see we are improving capacity in many countries to finally be able to report on hypertension control or understanding where are the lacks of essential medicines and technologies exist. But the data from, as I was mentioned, we need to have clarity on what the data provides to us. Data from facility are essential, but provides estimates, provide the idea of those that have gone to this facility. For when we need to look into the access to care, barriers to access of care, then we need to use different other sources to gather this information. And it's where telephone surveys come handy to help us fulfill these gaps. Next, please. And just one overview of what I was saying. We do have many tools, and you might know the tools that we have, protocols that we have for collecting information at the population level. Household surveys are key for measuring overweight and obesity, diabetes, and hypertension, for instance. School-based surveys are key. It's GSHS and GITS has been the tool that have provided information throughout for more than 2 decades in terms of NCDs and risk factors, mostly risk factors in the youth population. But here we needed a tool that would help us to understand gaps in policies and intervention. So telephone surveys come handy in this point. Can you please next? And that's how we see valuable. But most of the time, when we look into telephone survey, the first questions we have is, what is the penetration? What is the distribution? How are the coverage of population using telephone survey? And specifically here, I want to show and talk about mobile phone surveys, which is the experience we have had in the region. We developed one tool and one approach during the COVID pandemic to produce data for NCDs and data related with COVID as well. But this is a report launched by ITU, the International Telephone Union, in 2024. And then you can see the distribution Dr. Jarbas Barbosa mentioned in the beginning of this webinar, that we have an environment that facilitate in the region the use of mobile phone survey. He mentioned 4G and 5G, but if you look at as well with 2G, which is an element that facilitates use of CATI mode, would be essential for us to do. We still have some gaps in the rural areas, but the coverage at urban areas is almost 100% when you look into all the technologies. Population in the region of the Americas, the majority of population live in urban areas as well. But again, we have challenges. We need to look into the places that we might not be capturing well, but this is a very important tool for us to use. Also, in the region of the Americas, we look into the distribution of ownership of mobile phone surveys. And if you look at the distribution between male and female, and the region is pretty much 1 by 1. So we have the possibility of reaching different groups when we look into the ownership of mobile phone service. Next, please. And this is the question that everybody makes, right? When we talk about mobile phone, what is the coverage? And this is, if you look in the bottom, the different types of technologies. So 2G, 3G, 4G, 5G, and how this is available in different countries in the region. As I think to help you, to guide you to understand this, the majority of the population, or more than 75% of the population, have at least one of this coverage. And we, for the one that we are promoting, the use of CAT, requires at least 2G to be able to apply. So the region, we are pretty good in terms of mobile phone network. There are some countries that we need to be aware of the coverage, for instance, for 3G, if you want to use the technology farther, but which is Haiti, Guyana, and Cuba. But 2G is also much available in the region. Next, please. And now I want just to emphasize this approach of using mobile phone surveys and our experience in the region. What are the areas for NCDs that we should think better that we should take into consideration to gather information? So mobile phone surveys or phone surveys are useful for producing data in a timely, can be representative of the population, complements our routine surveillance and household surveys, our facility-based data that we need so much. It's very useful during public health crisis. We saw this during the emergencies, during the COVID-19. it helps us to look into our best buys. We know so far in the region which countries are really have passed laws or have policies to respond to the best buys. But here we can kind of go into the population, see what is their exposure to these policies as well, asking about knowledges, attitudes, and practices. We also can track the unhealthy commodities, and I want to give the example of the new emergent tobacco products, which is something very important to us to understand the dynamics within the populations and in the different countries as well. So, and finally, just to mention one of the area that we haven't explored much, but it's important, which is to know more, use this tool to know more about the barriers to access of care. Next, please. Brief overview, you see the methodology available at the PAHO website. We developed this during the COVID time in collaboration with CDC and RTI. So it aims to adult population. That's how we have tested so far. We recommend using short questionnaires to address specific needs. We have used, and we think, the best modes so far. There are so many exercises and there are people investigating better, but so far it seems for the region, the CATI mode is the best mode to be used, but you need to train interviews. The sampling we are using, probability sampling of mobile phone numbers. We stratified by mobile network operators. In a few countries, we were able to stratify by some geographic areas. I think it was the case of Bolivia, if my mind is not tricking me wrong. And then we allocate the sample based on the distribution of country population by sex and age. We selected the numbers using random digit dialing. It's nothing new that or different that people that work in sampling and surveys and does not know. In our experience, we are recommending mobile phone survey for the reason that the population is moving to this. Landline service has not been included in our experience. And this is one point that has been key. We had the opportunity to do this service in 4 to 5 weeks and get the information for different situations. And I think this is a valuable, let's say, feature in our surveillance toolbox to have. Next, please. And just one overview of what we have done so far. So we started this experience in using mobile phone survey in 5 countries as phase 1 during COVID. You all know the service interruption impact a lot on the life of those living with NCD. So we were asking about interruption of treatment because COVID. We were able to understand better this in countries. We later on tested using questions for policies and interventions related with best buys, which also adds more information for many strategies and policies that we are aiming to implement. And now in the 3rd phase, in collaboration with Bloomberg WHO, we are implementing a questionnaire in Ecuador where we are looking into the best buys, new emergent tobacco products. And we are very pleased to have Dr. Tom Frieden here because we have collaborating and he will speak a lot about the use of questions to gather information for primary healthcare. So those are elements that we are seeing key for us to complement our surveillance toolbox to get data that is needed. Please, next. And just to illustrate now, so if we look into the best buys data from some of these countries, we have Suriname and St. Lucia that were interested in knowing more about the campaigns that they have developed for increasing physical activities to understand how these campaigns that they were doing were penetrating within the population. Next, please. We also had data, and I'm pleased to have colleagues from Uruguay here today, and to understand better one of the best buys, which is bans on or comprehensive restriction on exposure to alcohol advertising. So you can see in the population where people are seeing advertising for alcohol in different medias modes. Next, please. And also look into understanding what is the perception or awareness of the population that think that e-cigarettes or vaporizers with tobacco are less harmful than cigarettes. We clearly can see that among the young males, among this population, they see this, that it's less harmful. So it's important of us to know as surveillance to identify where are the areas, where are the population that has been more targeted by these advertising, promotion, sponsorships, and the population. I think next, and finally, to illustrate, this is what I was mentioned that we use during emergencies, during the COVID-19 pandemic. Within all these countries, we asked the population, those that were diagnosed with high blood pressure, those that were using medication for hypertension, but they had to stop because COVID. So this is a panorama that we using telephone surveys, we can quickly gather information. Next, please. And to finalize, just to mention that the value of these tools is to complement what we have and to use these two features that we can produce data in a rapidly and flexible way, adjusting to needs. Here, we can produce information specifically for a special initiative in a country. For instance, if there is a need to understand better in terms of ultra-processed food or in terms of nutrition, we can produce the information in a more quick way to support some policies, to support decision makers, to push for policies that will protect population from these unhealthy commodities. We can have it as a time series, as Brazil has done and will share with us today, how they have been using the information throughout the years to really guide them on the direction of NCDs and the risk factors as well. And we can explore it to initiative. We could use this tool to produce data for many countries and have comparison to understand better these dynamics in different health systems of the barriers to access. So we can have compatibility as well and produce in a big number of countries this information. And finally, I mentioned before the use of this during public health crisis. I also want to say that there are a lot of potential for improvement on the sampling strategies, using household surveys to establish a panel to follow up, or even to follow up with those that are having access or not to healthcare facilities. So, and now we'll stop here and thank you very much. And I'll look forward for the continuity of our session.
That's wonderful. Thank you very much, Roberta. That was Roberta Caixeta, the PAHO Regional Advisor for NCD Surveillance. Excellent summary of the RAMP survey. RAMPS is the Rapid Mobile Phone Survey. And as she noted in her slide, we have the tool available on the PAHO website, and we encourage everybody to reach out to Roberta and visit the tool on the website to learn more about it. We also have a tremendous amount of data that's generated by the surveillance team on NCD mortality, morbidity, monitoring of trends and indicators available on the PAHO Enlace website. And we'll put the link in the website for those who want to access our data. So thank you again. And moving along in the program, we're really excited to have our next presenter, Dr. Tom Frieden, who's the president and CEO of Resolve to Save Lives, a true public health advocate known to many of you who are on this call. And he's sharing some of his time and expertise with us today to talk about monitoring access to NCD quality of care. Over to you, Tom.
Thank you very much, and felicitaciones, Roberta. It's very impressive work. I'd like to talk with you about monitoring access to NCDs and a really important approach that Brazil and Colombia and other countries in the region have started. as have other places around the world. So I want to start with a story that earlier this year I was visiting India, where we have partnerships, and I met Jagannath. He's a 70-year-old man, perfectly healthy, except he was feeling that his back was hurting. So he came in for care, but because they screened with a validated blood pressure monitor, they found out that in fact he was not okay. His blood pressure was dangerously high, verified on multiple retakings. He had no idea that he had high blood pressure. But because the WHO Hearts protocol, which is being implemented in many countries of Latin America, was being implemented there on that very same day, as per policy, he was started on treatment. And so he was happy, I was happy. His risk of having a heart attack or stroke was drastically reduced, and he also got treatment for his bad back. The fact is, we've had 50 years of commitment to primary health care, but other than in Latin America and parts of Europe, not a lot of progress. Latin America and the Caribbean have achieved some important areas of progress, but still in the NCD care, there has been real gaps in quality. We don't have the kind of focus on control that we have in the communicable diseases, which has been so important in driving progress from the tip to the toe of the Americas with terrific projects and programs. Most NCDs could and should be treated in primary health care, as Jagannath's hypertension was. Quality of care begins with quality data. Each method has strengths and weaknesses. Each method has its place and has unique information and perspectives. Health information systems are very important, and I'll discuss that more in a bit, but they miss people who aren't coming in for care. Facility-based surveys have value. Examination surveys are very important because we'll never get valid community-wide control data without examination surveys. You can't find out through the phone yet what someone's blood pressure is, but phone surveys also have a very important role. I do want to mention something I encourage you to visit, www.hearts360.org. This is an example of the hypertension dashboard. What we've learned is that in clinical care, dashboards are powerful, but work lists are even more powerful. And the Hearts 360 dashboard, which is available, and we would love to have partners in promoting this, is a way of rapidly improving care in primary care, and it gives you really important data. If you are the healthcare system, you really need to know one thing: how many patients are on treatment adequately controlled? And for patients with diabetes, that's especially important. And you want to know how many people with diabetes are on a statin. All of these things are basic. In the infectious diseases, we hold programs accountable. What's your tuberculosis success rate? We haven't done that in the NCDs, but we need to. And I know that the Latin American and Caribbean region can be an absolute pathfinder in this area. So I look forward to seeing further progress. Only Costa Rica reached the 50% mark from the region, not the US. Oh, sorry, and Canada, Costa Rica and Canada both. But other countries down in the 20% rate or 30% rate or 40% rate. But to get at least half of all of the people who have high blood pressure on treatment and controlled, if we did that globally, it would be 76 million lives saved. So it's very important. Now, moving on to the question of phone surveys, population surveys are an underutilized tool, and they've been called for by WHO, by PAHO. You heard the very strong message from Dr. Barbosa, who I've known for, Jarbas Barbosa, who I've known for many, many years. And he's right. And so how can we do this? Population-based surveillance captures the missing voices. It documents financial and other barriers to care. It reveals the true disease burden because population surveys consistently show higher NCD prevalence. It also identifies intervention priorities, what's working, and it addresses the lived experience of patients, and it can track differences among areas, over time, and among countries. New questions can be incorporated into ongoing surveys. So we began this project, almost 2 years ago. And really the model for it, and I was really glad, Roberta, to see you mention the global tobacco surveillance system. One part of that is what's called TQS, or Tobacco Questions for Surveys. These are the core of the core. It only takes 2 questions with very clear skip patterns to get standardized tobacco use, smoking prevalence, that we can compare apples to apples, one country to another, one part of the country to another part of the country, one part of the country last year to next year to 5 or 10 years from now. That's a great surveillance system. PAHO has been in the lead in that. Many of your countries are implementing this. And you can see some of them here. This is actually a graphic from 10 years ago. So there are many more countries by now. But here's the striking thing. We don't do this for primary health care. And that's what led to the Primary Healthcare Questions for Surveys, or PHCQS project, to develop a globally standard model of population surveys, which can be phone or in person, some places prefer in person, to enable countries to assess, improve, and expand the availability of services, to inform evidence-based policies and assess whether our programs to implement those policies are working or not. What gets measured can get managed. What doesn't get measured is unlikely to get managed. And what we saw strikingly is that there has been a project through the United States-based Commonwealth Fund in OECD countries, including some in Latin America, to track primary health care. But except for one-time survey in the Caribbean, this had never been done in lower or middle income countries or elsewhere, though many countries have this, but it hasn't been standardized. So we began a collaborative process. We don't claim to be the experts. We do want to convene others. So we had 15 countries, many global organizations, and then we had 2 countries volunteer to pilot test this, Brazil and Bangladesh. And we identified specific domains: availability, accessibility, affordability, and acceptability. This was the consensus of the group, that we needed to have all of these 4 included to get to the basic question of, how is primary health care for you? And there are specific questions for each of these. Availability. When you need routine health care, is there one person or place you usually go to? Accessibility. In the past 12 months, was there a time when you had a health problem and needed medical attention, but you did not get health care from a provider? Affordability. In the past 12 months, was there time you had to borrow money or sell valuables to get care? And I'll share with you some striking information about that from the PVS, the People's Voices Survey, which is a closely analogous project for a standalone survey. For this survey, we're really hoping that these core of core questions you can incorporate into various surveys. We're discussing with the STEPS group to include in those surveys. We were discussing with DHS to include in those surveys, but I don't know what's going to happen with DHS. Acceptability. Were you received well? Would you recommend this service to others? And I have to really give a shout out to Colombia, which had done this so well that they were able to tell us, well, these 2 different questions give you different answers, and they're useful for different things. So very important insights. The vision is to standardize this, to integrate it into different platforms, and then to have it. We've been talking about Alma-Ata 50 years, Almaty, primary care, but how will we know if we're there? How will we know if we're making progress? This is not the only way, but this is one way. What do people say? Because unless you do a population-wide survey, you may be fooling yourself. You may think people have care, but they may not be in care. There are other ways that are very important as well, like Hearts 360 within the healthcare system. Now, this is striking data from Nigeria, which implemented the People's Voice survey, and that has triggered more interest in providing medications with lower or no co-payments. But strikingly, a large proportion of people had to either borrow money or sell things to get routine or ongoing care. In Colombia, extensive experience, and it led to changes in which, as I understand it, which insurers were approved to continue. In Bangladesh, very interesting, although many challenges, very high level of satisfaction with care, very different from another country where the reported satisfaction of care was very low. Well, some countries have cultural differences in what expectations are, but still, you have some benchmark there. You can compare it male, female, young, old, urban, rural, different provinces of the country, different countries at the same time, the same country over time, as Colombia did, different insurers within the country. So this is a very powerful technology. And we just hope that more people will put this into your ongoing surveys. And with that, we'll have more valid, more important, and more reliable data to track where we are with primary health care and to steadily improve the quality of our implementation. Latin America, I will say, and PAHO have been absolute leaders in so many aspects of health and of primary care. And we look forward to seeing you achieve great things with improving care of people with high blood pressure, improving statin use for people with diabetes, and we know that you can make huge progress. So hats off to you. Thank you for the great work you do, and we look forward to continuing to collaborate with the PAHO office and with countries throughout the area.
Wonderful presentation. Thank you very much, Dr. Tom Frieden, President and CEO of Resolve to Save Lives, talking about the importance of integrating questions in your surveys that address primary healthcare services for NCDs. And we saw the value of having that data to really help influence changes in policy. We all know that in Latin America and the Caribbean, we have huge gaps in access to services. In fact, some surveys show that about a third of the population still doesn't have access to primary healthcare services. And in the NCD space, we know that there are large gaps in underdiagnosis, undertreatment, and in control. In fact, we know in hypertension that only about a third of the population with hypertension are actually achieving control. And Dr. Frieden reminded us today that we must take advantage of every opportunistic visit to a health clinic to measure people's blood pressure and diagnose hypertension and offer treatment, of course. So thank you again, Dr. Frieden, for your excellent presentation, for the wonderful partnership and collaboration with PAHO on the HEARTS initiative, on salt reduction, trans fat elimination, and public health overall in general. So thank you again very much.
Thank you.
Okay, great. So we're going to continue in the program. Vamos a seguir en el programa y solo para recordarles que tenemos traducción simultánea en el botón que dice interpretación, porque la siguiente presentación será en portugués. The next presentation is going to be in Portuguese, so I'd like to remind everybody we have simultaneous translation. It's in the bottom button titled Interpretation. And in this session, we will hear about the experience of Brazil with Vigitel and using telephone surveys for NCD surveillance. And I'd like to welcome Dr. Luis Antonio Menezes Jr., who is the General Coordinator of NCD Surveillance in the Ministry of Health in Brazil. Thank you for joining us, Luis. Over to you.
Olá a todos, boa tarde. Como comentado, eu vou fazer uma apresentação na minha língua materna, português, e conto com a colaboração dos colegas para fazer a tradução. Então, inicialmente, em nome da diretora Letícia, da coordenadora Georgia, eu gostaria de cumprimentar a mesa e os colegas da OPAS pela importante palestra e agradecer pela oportunidade de participar desse webinário que é tão estratégico. Então, é uma honra estar aqui representando a Coordenação Geral de Vigilância de Doenças Não Transmissíveis do Ministério da Saúde do Brasil, nesse espaço de diálogo e cooperação tão importante. Então, eu agradeço também a OPAS pelo convite e Nessa apresentação, eu vou trazer um breve panorama da trajetória do Vigitel, né, que é o nosso sistema de inquérito telefônico, já mencionado pelos colegas, que há quase 20 anos tem monitorado os fatores de risco e proteção para as doenças crônicas não transmissíveis e alguns agravos no Brasil, e destacando algumas das inovações recentes que vemos implementando. Então, para contextualizar, o Vigitel está inserido no escopo do Departamento de Análise Epidemiológica e Vigilância de Doenças Crônicas Não Transmissíveis do Ministério da Saúde, especificamente sob a coordenação, né, da CGD-NT, e a nossa atuação, então, ela visa subsidiar a formulação, implementação e avaliação de políticas públicas, e as ações elas são planejadas de modo a incidir sobre determinantes e condicionantes da saúde, né, a partir da mobilização e também a articulação intra e intersetorial. Então, a partir da coleta sistemática e análise desses dados, assim como também a disseminação de informações produzidas, a gente então consegue avançar nesse cunho tão importante. Então, o Vigitel ele é um dos 3 principais inquéritos coordenados aqui pela coordenação. Então, a gente tem também a PENSE, né, que é a Pesquisa Nacional de Saúde do Escolar, que a gente já tem desde 2009, com a coleta mais recente em 2024. A Pesquisa Nacional de Saúde, que é a maior pesquisa domiciliar do Brasil, com edições em 2013 e 2019, e a terceira edição em desenvolvimento. E, por fim, né, o que eu irei comentar, que é o Vigitel, que é o nosso inquérito telefônico anual, que vem sendo realizado, então, desde 2006. Então, a gente está com o relatório do Vigitel 2024 em fase final de elaboração e a coleta do Vigitel 2025, ela já está em campo. Então, esses 3 instrumentos, né, embora com metodologias e cronogramas distintas, eles se complementam para formar um sistema robusto de vigilância das doenças crônicas não transmissíveis no Brasil. E permitem, então, monitorar, né, não apenas os fatores de risco e proteção, mas também o progresso em direção às metas do Objetivo de Desenvolvimento Sustentável e também do Plano de Ações Estratégicas para o Enfrentamento das Doenças Crônicas Não Transmissíveis do Brasil. A construção do Vigitel, então, ela foi fortemente fundamentada em 2 grandes documentos estratégicos da OMS. O primeiro é a World Health Report 2000, que destacou a necessidade, né, de aprimorar o desempenho do sistema de saúde, incluindo a vigilância como uma função essencial de saúde pública. E o segundo é o STEPS, né, que apresenta, então, uma proposta para a vigilância padronizada desses fatores de risco. Com foco, obviamente, na simplicidade, comparabilidade internacional e a viabilidade também para países de baixa e média renda. Essas diretrizes elas foram fundamentais para o delineamento do Vigitel, buscando, então, aliar nesse rigor metodológico também com a viabilidade operacional, adaptando à realidade do Brasil. Bom, trazendo um pouco do histórico do Vigitel, então ele tem uma trajetória marcada por inovações e adaptações contínuas, né? Então, o Vigitel ele se inicia entre 2003 e 2005, quando foram realizados os primeiros pilotos, né, inicialmente na cidade de São Paulo, com aproximadamente 2.000 entrevistas, e depois expandindo para as outras 5 capitais, com um total de aproximadamente 10.000 entrevistas. Essa fase, então, foi crucial para testar e validar a metodologia, né, que foi desenvolvida em parceria com a Universidade de São Paulo, a USP, e em 2006, então, nós implementamos oficialmente o sistema em todas as capitais brasileiras e também no Distrito Federal. Um diferencial que a gente mantém até hoje, né, é a agilidade, que é importante, né, para que esse sistema de monitoramento ele aconteça. E com o avançar, especialmente no ano de 2020, também com a pandemia, a gente teve vários desafios, né, mas também oportunidades. Então, a gente teve que operar com algumas amostras reduzidas, mas garantimos, né, conseguimos garantir a continuidade do sistema. E 3 anos depois, né, em 2023, a gente deu um passo importante, né, assim como comentado pelos colegas, que é a incorporação das linhas móveis, ampliando significativamente a cobertura populacional. E, em 2025, um novo marco se inicia, né, então, pela primeira vez, o Vigitel ele está sendo expandido para municípios do interior, não apenas os municípios das capitais, aumentando ainda mais a representatividade dos nossos dados. E também, paralelamente a isso, eu vou mencionar mais à frente, implementamos também uma estrutura denominada como core e rotativa, que nos permite uma maior flexibilidade na investigação, então, de temas emergentes em saúde. Então, na primeira edição do Vigitel em 2006, como eu mencionei, a agilidade ela é um ponto-chave, né? A gente gostaria, né, de mencionar, por exemplo, que em 2006 a gente conseguiu publicar os resultados em menos de 70 dias, após o encerramento das entrevistas, tendo aí um marco de vigilância, né, um marco para a vigilância em saúde. Então, os indicadores do Vigitel, eles são definidos com base em metodologias consolidadas internacionalmente e pesquisas nacionais, garantindo a comparabilidade e relevância. E aí a gente tem várias fontes, incluindo, né, o BRFSS, o STEPS, a Pesquisa Mundial de Saúde, as pesquisas conduzidas pela coordenação também, que são a PNS e a PENSE, a Pesquisa Nacional de Saúde Escolar e a Pesquisa Nacional de Saúde, a Rede Carmen, né, traz algumas diretrizes para a vigilância de doenças cardiovasculares nas Américas, e também um passo muito importante são a realização de oficinas, né, que vários colegas até da OPAS participam, a partir do momento onde a gente tem, então, atualizações temáticas, né, com especialistas do Ministério da Saúde, da comunidade civil, da academia, né, das universidades, para a inclusão, então, de demandas emergentes, aprimoramento de questões, né, e essa pluralidade, né, de fontes faz com que o Vigitel ele alinhe, então, padrões globais com as prioridades de saúde pública brasileira e das Américas. Então, em relação aos indicadores, ao longo dos anos, o Vigitel ele acumulou um portfólio robusto de indicadores, né, que vão desde estado nutricional, alimentação, atividade física, morbidades referidas, comportamentos de sono, foi um avanço recente, muito importante para a temática, né, de saúde, especialmente de doenças crônicas não transmissíveis, além também de outros indicadores, como a prevenção de câncer de mama e de colo de útero, o uso do álcool, tabaco e também comportamentos no trânsito. Nós também, além desses principais temas, né, que que nos acompanham, né, desde o Vigitel, desde os primórdios, né, a gente também tem inserções pontuais sobre temas emergentes, como é o exemplo da saúde bucal em 2009, ações de combate à dengue em 2012, aspectos relacionados à Covid-19 em 2021, meios de proteção contra raios ultravioletas em 2007 a 2010 e mais recentemente também a inclusão de questões relativas a apostas online em 2024. Bom, em relação então à metodologia do Vigitel, ele foi originalmente desenhado, né, em 2006, considerando, como assim trago pelos colegas, que a cobertura de telefonia fixa nas capitais brasileiras permitiria então uma amostra representativa da população urbana adulta, né? Então, no entanto, né, com a queda acentuada no uso de linhas fixas e a mudança nos padrões de comunicação, o sistema, então, precisou passar por um processo de atualização metodológica, culminando, então, na inclusão da telefonia móvel em 2023, para manter a sua representatividade. Então, essa metodologia ela começa, né, com um sorteio aleatório de cadastros telefônicos, né, cuja fonte ela também evoluiu ao longo dos anos. Então, inicialmente, essa fonte de dados ela era obtida diretamente das operadoras, né, no qual a gente tinha informações do CEP, informações da localidade daquela linha telefônica até 2013. A partir, né, desse momento, de 14 a 2020, a gente não tem mais a inclusão das linhas telefônicas. E, atualmente, a partir de 2021, a gente então utiliza os cadastros compartilhados pela Anatel, e que são organizados, portanto, em réplicas municipais, que nada mais são do que conjuntos de amostras aleatórias que garantam, então, a cobertura proporcional em cada capital. Então, na coleta, as linhas móveis, elas permitem o contato direto com o indivíduo, né? Então, diretamente com o indivíduo participante, enquanto nas linhas fixas é necessário, portanto, um segundo sorteio para selecionar um adulto, no caso do Vigitel, com 18 anos ou mais, né, no domicílio selecionado. E, posteriormente a esse processo, né, para corrigir as possíveis distorções amostrais, é aplicado, portanto, uma ponderação pós-estratificação, que atualmente no Vigitel ela é calculada pelo método Reiki, e com base, né, no censo populacional, ajustando, portanto, por sexo, faixa etária, escolaridade e, mais recente, a cor da pele, assegurando que a distribuição sociodemográfica da amostra se iguale à distribuição estimada para a população total de cada localidade avaliada. Bom, Desde a implementação, em 2006, o Vigitel tem mantido um desempenho operacional estável, mesmo diante de mudanças nas tecnologias de comunicação e nos padrões de uso, né, da população. Essa estabilidade ela é importante, né, porque garante para a gente a comparabilidade temporal dos dados coletados, mas a gente observa uma queda gradual nas taxas de elegibilidade das linhas telefônicas ao longo das edições. O que reflete um pouco, né, qual é, né, o local de onde vêm essas linhas telefônicas. Então, isso a gente percebe especialmente no ano de 2023, né, onde, em telefones fixos especialmente, né, que pode ser um reflexo do aumento de linhas corporativas, fora de serviço ou inativas, e a necessidade, então, da inclusão de celulares, que atenuou parcialmente essa queda. Então, a gente tem ali, né, que a elegibilidade do fixo ela ficou em aproximadamente 5,3% das linhas telefônicas, já com os móveis, né, o cadastro de telefonia móvel alcançando 21,2%. E a gente, então, observa, né, realmente essa queda, né, uma variação média de 3 pontos percentuais desde 2006. E, mais recentemente, de 2018 a 2023, uma queda de aproximadamente 10 pontos percentuais por ano. Então, outro indicador importante é a taxa de resposta, que também apresentou uma redução ao longo do tempo, passando de 71,5% em 2006 para 58,7% em 2023, nas linhas fixas, e exigindo, então, uma atenção, né, a esses cadastros que são utilizados para o contato. Porém, né, apesar desses desafios, a gente percebe que o percentual de recusa ele tem se mantido favorável, né? Então, em 2023, a gente ficou com 5,3% para fixos e 4,1% para celulares, e há também uma tendência de redução, né, nesse indicador de percentual de recusas, o que reforça, né, a qualidade da abordagem da pesquisa e também da atuação dos entrevistadores. Bom, então, um ponto importante é o tempo, né, de duração da entrevista, né, que a gente vem monitorando ao longo do tempo, e reflete a incorporação de novos temas, né, o que gera um dilema, que a gente precisa manter os indicadores tradicionais, mas também monitorar tendências de longo prazo, para incluir, né, novas demandas emergentes, sem comprometer a qualidade da coleta. E é por isso que a gente estruturou, né, a possibilidade de adotar esses temas rotativos, que são temas que são incluídos de forma alternada, permitindo flexibilidade para abordar diferentes assuntos, sem sobrecarregar o questionário e garantindo, portanto, espaço para novas temáticas. Então, esse ano, em 2025, como eu mencionei, é um marco muito importante para o Vigitel. Então, a gente teve o sucesso do processo licitatório e a gente está expandindo, como eu mencionei, o inquérito para os municípios do interior, né, ampliando a representatividade. E também estamos incluindo novos indicadores, né, especialmente sobre álcool, tabaco e bebidas adoçadas, que ganham destaque, né, no contexto da reforma tributária em discussão no Brasil. E também, né, a gente tem aí como um papel muito importante o fortalecimento dos canais de divulgação da pesquisa em conjunto com os parceiros. Então, o Vigitel, né, além dessas principais, né, estratégias de comunicação, o Vigitel ele passa a contar com novas ferramentas de coleta, né, de divulgação dos dados, como SMS, WhatsApp, assistente virtual, ampliando a transparência e a participação social. Bom, como perspectiva, né, então, em resumo, o Vigitel ele continua sendo um sistema robusto e estratégico para a vigilância de fatores de risco e proteção para doenças crônicas não transmissíveis no Brasil. No entanto, né, a gente percebe que o modelo ele necessita de acompanhamento e um constante aprimoramento. Então, um dos principais desafios é implementar estratégias multimodais de coleta. Então, nesse aspecto, alguns estudos pilotos vêm sendo delineados como painéis online, que demonstram resultados promissores, que são, em média, mais baratos e com tempo médio de resposta menor, porém, ainda exigem certos cuidados, porque também tendem a superestimar alguns indicadores e apresentar pequenas diferenças no perfil sociodemográfico dos respondentes. E o uso de painéis online para melhorar a usabilidade, eficiência e divulgação dos resultados vem sendo muito utilizado e bem recebido pela população. Então, isso é um aspecto muito importante. E, por fim, como mencionado, a ponderação, né, das estimativas por raça, cor da pele, traz também um outro avanço muito importante, garantindo maior precisão na representação das desigualdades em saúde e permitindo, portanto, o monitoramento das inequidades e direcionamento de políticas públicas mais equitativas. Então, a gente vem divulgando os dados dos resultados do Vigitel em painéis interativos, como o painel de obesidade, que está aqui apresentado, que está hospedado no Centro Nacional de Inteligência Epidemiológica, aqui da Secretaria de Vigilância em Saúde e Ambiente. E também outros painéis, como o Indica Dante, que está em desenvolvimento, que irá incluir informações sobre Dante, fatores de risco e proteção, com dados das pesquisas do Vigitel, a PNS e a PENS, e, portanto, oferecendo uma visão integrada dos fatores de risco e proteção para as doenças e agravos não transmissíveis, com acesso público e interativo aos dados. Então, por fim, eu deixo aqui os sites institucionais com mais informações para quem quiser, né, conhecer ou acessar os dados do Vigitel, e queria novamente agradecer, né, a OPAS pelo convite e a oportunidade de compartilhar a experiência brasileira, e estou à disposição para o debate.
Excelente, un millón de gracias, Luis. Excelente experiencia en Brasil con Vigitel, con las encuestas con teléfonos móviles. Y es un buen signo, ¿no? Que desde 20 años se ha podido lograr tantas encuestas y se ha mantenido, o sea que es una herramienta muy sostenible, ¿no? Así que muchas gracias por compartir esta experiencia y espero que sea muy motivador para los que están trabajando en el campo de vigilancia y que están considerando la implementación de estas encuestas con teléfonos móviles. Muchas gracias, Luis. Bueno, enseguida tenemos una presentación de Uruguay para que los colegas en Uruguay puedan compartir su experiencia. Tenemos Jimena Moratorio, la coordinadora del Programa Nacional de Nutrición del Ministerio de Salud, y Jimena Heinzen, quien es la coordinadora del Programa Nacional de Enfermedades No Transmisibles en el Ministerio de Salud, quien nos va a hablar sobre la encuesta RAMPS utilizado para medir la implementación del etiquetado frontal. Jimena.
Hola, buenos días para todos. Disculpen que estoy acá intentando compartir la presentación. Disculpas que se me fue. Bueno, puede fallar. ¿Se ve
Sí,
bien?
Sí, muy bien.
Bueno, primero que nada, muchas gracias por la invitación. Bueno, que en primer lugar fue extendida a Jimena Heisen, mi colega, y bueno, ella la extendió hacia mí. Nosotros claramente tenemos mucho menor experiencia, pero igual venimos a mostrar un poco cómo estamos tomando estos insumos en la definición de algunas medidas para abordar el sobrepeso, la obesidad y las enfermedades no transmisibles. Así que bueno, contándoles un poco nuestra política de etiquetado frontal que se inició en el año 2017, el proceso regulatorio que se hizo en Uruguay para llegar a una política de etiquetado frontal de alimentos constó de varias etapas. La primera fue conformar un grupo de trabajo interinstitucional, recopilar las evidencias internacionales, analizar la evidencia existente, bueno, seleccionar los nutrientes críticos y el establecimiento de límites para definir cuándo un producto tenía exceso, y bueno, y esto se basó en lo que son las recomendaciones internacionales, y específicamente, inicialmente Uruguay optó por adoptar el modelo de perfil de nutrientes, de la OPS, aunque después sufrió algunos cambios, que bueno, que no son el tema del día de hoy. También se generó evidencia local en este intercambio, trabajo siempre en conjunto con la academia. Se generó evidencia local que después fue utilizada por otros países para el desarrollo de sus propias políticas. Cada una de las decisiones que se tomó fue basada en evidencia, todas las características del sistema gráfico fueron respaldadas en estudios de investigación, y también en este caso se incluyó una encuesta de percepción de los consumidores sobre la adopción de esta política, que no fue realizada por teléfonos móviles, pero sí fue a través de medios digitales, ¿sí? Como un punto también de cercanía con el tema de hoy. Y esto, bueno, nos dio un insumo muy importante a la hora de tomar estas definiciones, ¿no? Porque sabemos que este tipo de políticas son muy cuestionadas, sobre todo por el sector industrial. Entonces, bueno, contar con la percepción favorable de la población en relación a que existiera esta herramienta para la toma de decisiones también fue muy importante. Bueno, luego se sometió el borrador a un proceso de consulta pública nacional e internacional. En el caso de la internacional, a través del Comité de Obstáculos Técnicos al Comercio de la OMC, se recibieron aportes, algunos aportes se incorporaron, se flexibilizaron los límites y se extendieron los plazos de aplicación. Finalmente, se firmó el decreto el 29 de agosto del 2018 y teníamos un plazo de implementación que iba al 1 de marzo del 2020. Luego la política surgió algunas, digamos, modificaciones, como todos sabrán, o gran parte del auditorio. Finalmente, luego de, bueno, un cambio en la administración de gobierno, pandemia de por medio, también la normativa sufre algunas modificaciones en lo que es el modelo de perfil que está vigente en este momento, y también una extensión de los plazos, y finalmente se aplica el 1 de febrero del 2021. Estas son las características de nuestro etiquetado frontal, imágenes, un sistema gráfico de advertencias nutricionales que es consistente con las recomendaciones de buenas prácticas de la OPS y que había sido puesto, ¿verdad? Como una de las que había sido validado por los estudios de investigación realizados en la población nacional. Estas otras son las características del etiquetado y el algoritmo de aplicación. Está dirigido a productos procesados y ultraprocesados porque solo incluye aquellos productos que tienen adición de nutrientes. Y bueno, y acá vemos cómo luce y las proporciones. Le doy la palabra a Jimena para que siga en este momento.
Bueno, gracias, Jimena. Había que llamar a Jimena para poder participar. No. En realidad, nosotras lo que queríamos compartir un poco era esta idea del proceso que había hecho Uruguay vinculado al etiquetado y cómo en las encuestas que propuso OPS que se implementaron en nuestro país permitieron de alguna manera evaluar aproximadamente a un año y algo, un año y medio aproximadamente de la implementación de la norma, cómo la población percibía eso y qué actitudes había frente a eso. Esto en verdad ya lo nombró Roberta hoy más temprano, pero en Uruguay específicamente se hizo a través de teléfonos móviles estratificados por sexo, pero lo que queríamos comentar es que se completaron un total de 2005 entrevistas, y lo que se destacaba hoy anteriormente en los otros panelistas, ¿no? Es un tiempo de recolección breve que permite contar con datos rápidamente. La encuesta en Uruguay tuvo varios módulos, pero lo que queríamos destacar hoy en función del impacto o de la posibilidad de evaluar determinadas políticas públicas fueron las conductas de compra o selección de alimentos vinculados al etiquetado frontal, la opinión o la percepción de las personas en relación a impuestos a bebidas azucaradas y alcohólicas. Se indagaron también hábitos alimentarios de consumo de alcohol y de tabaco. Otro de los elementos que también se relevaron fueron accesibilidad y opiniones y percepciones vinculadas a COVID-19 y las vacunas de COVID-19, porque como les decía recién, los datos fueron recolectados en octubre de 2022, aún estábamos en pandemia. ¿Pasa a la siguiente? Ahí está, y simplemente para compartir con ustedes algunos resultados. Acá no está desagregado por sexo, que fue uno de los resultados que se presentan también estratificados por sexo, pero el porcentaje de personas que visualizaban el etiquetado frontal fue un 76,7%, ahí está señalado el intervalo de confianza. Y una cosa que nos parecía interesante destacar es con respecto a las decisiones de compra, o sea, hasta dónde esta normativa o la colocación del etiquetado frontal influía en las decisiones de compra de las personas. Están diciendo que no se escucha, no sé si eso es general o...
Te escuchamos bien, pero un poco lejos.
Ah, ok. Em, Entonces, bueno, aproximadamente un 60 o si juntáramos las personas que suspendieron la compra de algunos productos en función del etiquetado frontal y aquellas que las disminuyeron, llegaríamos a casi un 63, 64% de la población. O sea que es de las personas que respondieron a la encuesta, ¿no? Pero un porcentaje importante de las personas que participaron tomaron decisiones en función del etiquetado. La siguiente, Jimena. Acá para comparar, una de las cosas que mencionó hoy mi compañera es que en Uruguay se había hecho a 10 días de aplicada la norma, o sea, se aplicó muy verde, digamos, ¿no? Enseguida que se había aplicado la norma, se hizo una encuesta que no fue telefónica, como las RAMs, sino que fue a usuarios, personas adultas, mayores de 18 años, usuarios de redes sociales, o sea, a través de propagandas, de publicidad, en algunas redes sociales, las personas elegían participar y luego eso se ponderaba por sexo y por su distribución etaria y en el país. Tiene determinados sesgos esa metodología, pero en realidad una de las cosas que se refirió o que nos interesaba señalar es que también al solo 10 días de aplicar la norma, algunas personas planteaban, bueno, que un porcentaje muy elevado la conocía y un porcentaje del 58% de las personas habían modificado sus decisiones de compra al visualizar los octógonos. ¿Sí, Jimena? Y bueno, finalmente con respecto, entendiendo esta herramienta como puede tener distintos usos, pero en este caso en particular nosotros lo que queríamos compartir era su uso como evaluación de opinión pública o de determinadas políticas públicas o de la viabilidad o la percepción de las personas como para impulsar algunas políticas. Nos pareció interesante señalar que un 30% de las personas encuestadas manifestaron que el aumento de precios o un impuesto vinculado a las bebidas azucaradas influenciaría sus decisiones de compra. En el mismo sentido, un poco menos, pero en el 25% de las personas, 25,5% de las personas, plantearon que se vería influenciadas sus decisiones de compra si hubiera un aumento en el precio de las bebidas alcohólicas. Y bien, este porcentaje, inicialmente uno dice, bueno, quizás es algo un poco más difícil de movilizar, ¿no? Es algo que está culturalmente muy imbrincado en nuestra cultura, el consumo de alcohol. Un 67,5% de las personas apoyarían el aumento de impuestos en las bebidas alcohólicas. O sea que esto, si bien es algo que no se ha implementado aún en nuestro país y que en parte es algo de las líneas que estamos trabajando y evaluando, hay un porcentaje de la población que estaría afín a eso y es importante al momento de tomar decisiones. Y después lo otro, que ahora va a ahondar un poco más Jimena, es que el 76,6% de las personas que respondieron a la encuesta estaban a favor de la prohibición de venta de productos que tuvieran etiquetado frontal en centros educativos, que eso finalmente fue algo que se impulsó en nuestro país. Jimena, te doy la palabra.
Bueno, contándoles un poco en relación a esta última pregunta de evaluación, Uruguay cuenta desde el año 2013 con una ley, que es la ley 19.140, de promoción de alimentación saludable en centros educativos. Esa ley dispone a algunas competencias a varias instituciones y al Ministerio de Salud le compete establecer la lista de alimentos recomendados para la venta y publicidad en los centros educativos. Inicialmente esta ley prohibía la publicidad y la promoción de esos productos en los centros educativos, pero no prohibía así la venta. En el año 2022, luego de que ya estaba plenamente implementado el etiquetado frontal, se emitió una nueva ordenanza, la 212 del 2022, que aprobó un nuevo listado de grupos de alimentos, introduciendo el etiquetado frontal dentro de la clasificación, ¿sí? Son 3 grupos de alimentos. Por un lado, los alimentos y bebidas naturales o mínimamente procesados. El grupo 2 son las preparaciones elaboradas en el punto de venta, preparaciones más caseras con ingredientes recomendados. Y el grupo 3 aborda lo que son los productos envasados, procesados y ultraprocesados. Entonces se incluyó como condición que estos productos no pudieran tener etiquetado de advertencia nutricional. Posterior a la firma de esta ordenanza, se hizo una modificación en el mismo año de la ley 19.140, modificando el artículo que establecía las prohibiciones para que también abarcara la venta. Es decir, que desde el año 2024, esta política de que de alguna forma fue medida la percepción de la población a través de las encuestas telefónicas, se puso en práctica y hoy en día está prohibida la venta de productos con octógonos en los centros educativos. Por otro lado, varias de las medidas que también se pusieron a consideración de la población hoy integran lo que es la hoja de ruta nacional para la aceleración de acciones contra la obesidad. Bueno, como la mayoría aquí sabe, el plan de acción de la OMS para acelerar la acción contra la obesidad es un plan que está desarrollándose en varios países y Uruguay es uno de los países pilotos. Para esto se han seleccionado 4 medidas principales para desarrollar. Las medidas prioritarias son 4 en el caso de Uruguay, 3 de las cuales están vinculadas a las medidas que fueron evaluadas a través de las encuestas telefónicas. Tenemos fortalecer el marco normativo sobre etiquetado frontal de advertencias nutricionales, que es una política que, como ya les mostramos, ya está en marcha en nuestro país, pero que requiere robustecer su marco normativo para acercarse más a las mejores prácticas recomendadas por la OPS y también incorporar algunos aspectos vinculados a la implementación y las lecciones aprendidas. Bueno, como saben, esta evaluación es necesario hacer una evaluación, ¿verdad?, de lo que ha sido el impacto de la medida que ya se ha tomado con sus pros y sus contras, porque sabemos que la implementación ha tenido sus complicaciones por los cambios normativos, pero bueno, ya tenemos varios años de implementación y podemos evaluar en primera medida cuál es la percepción de la población, que ya contamos con esta información a través de las encuestas que se han desarrollado, incluida la encuesta telefónica realizada por la OPS y las otras encuestas que mostró Jimena. También debemos evaluar si ha habido cambios en los comportamientos de la población en la medida de disminuir el consumo de productos con octógonos, y esa es una evaluación que también se está iniciando con el apoyo de la OPS. Pero también se prevé en este plan impulsar el desarrollo de una normativa que permita regular la publicidad de alimentos y bebidas dirigidas a los niños y también desarrollar una propuesta normativa para aplicar medidas fiscales para reducir el consumo de bebidas azucaradas. Y bueno, vamos a incluir, por supuesto, en el análisis de esta medida lo que ha sido la evaluación de percepción de los consumidores, que bueno, esto también le da otro impulso y sabiendo, ¿verdad?, que son medidas sumamente discutidas porque sabemos que tocan intereses comerciales muy fuertes, contar con una evaluación positiva por parte de la percepción de la población y la utilidad de estas medidas para mejorar sus prácticas alimentarias es sumamente valioso. Así que bueno, esto es lo que teníamos para compartir con ustedes.
Muchas gracias a Jimena Moratorio y la otra Jimena también. I can't find your last name. A Jimena Heinzen. Sí, muchas gracias a los dos para mostrar los resultados de la implementación de la encuesta RAMS en Uruguay y cómo podemos apreciar de la presentación cómo se puede utilizar esos datos para conocer los cambios en comportamiento y también cómo se puede utilizar para cambiar las políticas, ¿no?, y promover la salud en la población. Así que muchas gracias a las dos Jimenas para compartir la experiencia en Uruguay. We have now come to the end of our webinar on NCD surveillance, and I just want to thank everybody once again, and particularly our tremendous speakers, Roberta Caixeta, Tom Frieden, Luis Menezes Jr., and we just heard from Jimena Moratorio and Jimena Heinzen for sharing all of their expertise, their experiences, and showing us the importance and value of doing surveys, and particularly telephone surveys. And I want to thank each and every one of you. We had about 400 people from across North and South and Central America and the Caribbean, and even from countries outside of the Americas region who participated. And we thank you for your time and your engagement, a lot of chat going on, a lot of questions and answers. And I think we have collectively reaffirmed the importance of surveillance as an essential public health function, and particularly in NCDs to monitor the NCD burden in terms of mortality and risk factor prevalence, but also to support the decision makers in establishing those policies, those healthcare interventions that can really help promote health, prevent NCDs, and better manage people living with NCDs. And we heard about how telephone surveys like RAMPS or Brazil's Vigitel can really help provide rapid, timely data and important data to help inform some of these policies. And these methods have been evolving as technology changes, as people's use of mobile phone surveys change. And I think there's such great potential to use these surveys in order to improve quality of care for NCDs, as well as the NCD prevention policies. And we know that throughout the region of Latin America and the Caribbean, there's promising environments because of the penetration of mobile phone surveys, of mobile phones, as Roberta showed in her presentation, with a lot of network coverage and high use. So as countries invest in building the NCD surveillance systems, and as many of you who are probably working in NCD surveillance are investing in strengthening the surveillance system, we encourage you to consider using telephone surveys and using the PAHO RAMPS survey, or using those core primary healthcare questions that Tom Frieden presented in your surveys to be able to complement the household or population-based surveys that are already ongoing. So let's continue to work together to help improve the capacity of NCD surveillance in our region, and to leverage all the digital tools that we have available to help improve NCD programs. PAHO, of course, remains committed to work with all of you to support member states in improving NCD surveillance and NCD programs overall. So thanks again, and I look forward to having you in our next webinar that we will be presenting, in fact, next week on July the 25th, where we're going to talk about NCD best practices, and we're going to focus on NCD primary prevention and risk factor reduction policies that countries in the Americas are implementing. So please join us next Friday at 11 o'clock for a continuation of our PAHO NCD series. Thank you, everybody. Have a great day. Muchas gracias a todos y a todas. Que tengan un buen día.
Muchas gracias, Silvana. Saludos a todos.